Oh, good morning, first of all. Okay, lovely to see you all. I don't think it's unreasonable to say that modern ultrasound is very underused, not fully utilized in gynecology, but in particular in this area, reproductive medicine and early pregnancy. And I think we kind of look at the basic formats that we have available to us. And this applies to all machines, all machines. I think that comment certainly applies to whichever facility we're looking at there. So in the brief time I've got, I'll just kind of go through these different areas and just kind of talk about what our machines are capable of giving us, both in terms of diagnostic effectiveness as well as influence on clinical managements. So we'll start with the basics. We'll start with Grayscale, 2D Grayscale. We move on to 3D Grayscale as part of that. First of all, what do we call a good Grayscale? In this age of computerization, it's very easy to produce cosmetically pleasing ultrasound images. But are they kind of realistic in terms of giving us the clinical information that we want? In terms of looking at the adnexal region, it's an ideal area to kind of check Grayscale. So if we look here at this is our dominant follicle, developing follicle there. In 80–90% of cases, we should be able to see the follicles clearly, the stroma clearly, and also blood flowing through the internal iliac vessels. Now, any machine will show you that by turning up the gain, but you lose the clarity within the cystic anechoic areas. And we expect the same level of contrast resolution, Grayscale, as well as spatial resolution with our 3D components. That section there is produced by the favorable part of the ultrasound beam. This section there is produced by the non-favorable part of the beam. But if it's a good machine, a reasonable machine, then you should get the same Grayscale spatial contrast between those two sections. Just the other ovary just producing the same effect. And also, we're not just interested in pre-ovulatory ovarian changes. We're very interested in what happens after ovulation, as you'll see later on in the talk. So we need good contrast to show us hemorrhagic luteal cysts. We do show them better once we put on the SMI, as you'll see later on, but this is the kind of Grayscale that we expect from our advanced ultrasound systems. And we look at here, we see the follicles there. This is blood flowing through adnexal vessels. This is hemorrhage, free fluid hemorrhage, peri-ovulatory changes. So our Grayscale capability needs to produce this kind of imaging, this level of imaging. So again, as I said, this applies to 3D as well as 2D. And make sure that with your 3D imaging that this component and that component, the parasagittal, the coronal sections, are comparable in terms of both contrast resolution as well as spatial resolution. So if we look at two areas where, in particular, where Grayscale is important to us, certainly in terms of reproductive medicine, also really in terms of general gynecology. Let's just start with the endometrium. The endometrium. This is the endometrium. There is no such thing as a triple layer. It's something that's been introduced by the world of IVF, but there's no such thing as a triple layer. Our grayscale appearances of the endometrium reflects diffuse glandular changes within the stroma of the endometrium. We see the glands proliferating from the basal region towards the superficial region. These are the kind of images that we should be looking at now with our grayscale imaging. We realized back in 1984 that as we go through an ovulatory cycle, the grayscale appearances of the endometrium changes. And as we kind of move from our early follicular phase all the way through to ovulation, post-ovulation, there are textural changes. There are textural changes that tell us this is a good ovulatory response. These are textural changes that tell us when to perform our ART procedures, whether it's IVF, intrauterine insemination, and so forth. So if we look at those images a bit more closely, so this is our endometrial appearance early on in the cycle. Think in terms of follicular phase, periovulatory phase, rather than their secretory proliferative phases. And even at this early stage, we should see echoes within the endometrium. If you have a decent system with decent grayscale, this should not be anechoic. We should see the basic glandular tissue before periovulatory proliferation occurs. As we move through the cycle, we can see the endometrium not only gets thicker, but we can see there are changes within the stroma. And as we get towards ovulation, this is the day of the LH surge. Again, you can see it's looking fairly solid. You can see the impression there of these glandular changes that we want to see within a developing endometrium. And certainly, once we get to ovulation itself, then you can see this quite significant change in terms of the endometrial appearances. And we can carry on into the luteal phase, and that's important to us, as you'll see shortly. And this is the endometrium, 7 days after ovulation in a conception cycle. And we can compare that with a non-conception cycle where you can see the endometrium is beginning to break down 8 days after ovulation. The endometrium breaks down from the superficial surfaces towards the basal region. So we can actually tell which cycles might well be conception cycles very early on, and certainly we can confirm which cycles are going to be non-conception cycles very early on. So with the endometrium, it's very important to look at the grayscale. We must have this grayscale capability. We also use color Doppler, this is SMI actually, and it's monochrome, in terms of looking at the endometrium. This endometrium is too thick. This is too thick. We know this is a proliferative endometrium. You can actually see the arcuate vessels there and capillary vessels. This isn't pathology. This isn't pathological. This is functional. In this case, there's a bit of retained tissue from a previous miscarriage. So this endometrium is too thick. It's probably related to estrogen dominance, but it's important information. It's important information that our grayscale gives us. If we go to this endometrium, this is a patient who's about to go off and have an egg collection. This is not a good endometrium. That lady was given a trigger injection on the basis of this endometrium, and she didn't conceive, which comes as no surprise to us because you can see it's flat. There's no element there of glandular activity. And likewise, if we take this example, 11 millimeters, that's not a good endometrium. in terms of imminent ovulation. Again, you can see there's no glandular activity there. So this is the importance of having good grayscale if you're offering any kind of fertility investigation, fertility treatments. So just kind of go back to our Doppler. You know, we can pick up the spiral arteries here very, very nicely. And it means that when we look at the endometrium, you know, we're not just looking at thickness. Thickness actually tells us very little about the quality of an endometrial response. It tells it's thickening up, but that's all. It doesn't tell us whether it's a good response, a poor response. And really, we need to respect the endometrium and treat it like an individual organ. And when we assess it, we look at thickness, texture, the delineation between the endometrium and myometrium. This is an area in where elastography becomes of interest, but we wouldn't call that a routine element of our imaging. And vascularity is very, very important. So that's how we approach looking at the endometrium. That's what we want in terms of looking at endometrium from a grayscale point of view, also from a vascular point of view as well. If we look at this endometrium, it's 14 millimeters of endometrium there. This is an inaccurate measurement, This emphasizes the need for 3D grayscale. Because if we do a 3D sweep, within 10 seconds, we find that the lining is actually 8.8 millimeters, not 14 millimeters. The uterus is rotationally displaced. We know that uterus can be laterally displaced, be retroverted, antiverted, but it can also be rotationally displaced. You can't overcome that problem with routine transvaginal scanning. Here's another case here. This is what we would perceive as a parasagittal section, but when we manipulate with the 3D, then we get an accurate measurement of endometrial thickness. And we looked at a number of patients who come through fertility treatment, and you can see that there's a significant number of patients who are having their endometrium measured inaccurately because of this situation with rotational displacement. So this is why 3D is important or this is one of many examples of why 3D is important to us in terms of our infertility work. The other area is adenomyosis. And, okay, we've got severe adenomyosis then. We should recognize that on our grayscale imaging. And these are the changes that we would associate, characteristic changes that we would associate with adenomyosis. And I think most people would agree with that. But we need to pick up adenomyosis at an early stage, because adenomyosis is very estrogen sensitive. And if we're given estrogens as part of infertility, then it's going to affect the level of adenomyosis. Secondly, it's a way of telling us that the patient has endometriosis in the absence of any endometrioma on the ovary or any nodules within the pelvis. And certainly the kind of grayscale that we want from our systems it's able to tell us whether patients have adenomyosis at a very, very early stage. This is the same patient. If we look at the myometrium there, this is the myometrium around day 3, day 4. You can see there's no endometrium there. And you look at the myometrium around ovulation, just after ovulation, you can see the textural changes there within the myometrium. If we take this example here, this is a scan around the time of the period, just after the period, day 3, day 4. You can see evidence there of glandular changes within the myometrium. Same patient, this time just after ovulation. Those changes have gone. Those changes have disappeared. And this is what we want from our grayscale. This is what good grayscale is all about. Here's a patient who's gone through several cycles of estrogen treatments, part of an ovum donation program. And this is, I think this is kind of earlier this year. You look at the myometrium there, it is kind of slightly irregular, but this is recent appearances after several cycles of estrogen therapy as part of that infertility treatment. So you have to be very, very careful in terms of the management of infertility, particularly if there is evidence of adenomyosis picked up at an early stage. And if we take this case here, this is our post-menses scan. You can see the changes, the myometrial glandular changes I was alluding to. And you can see how, when you get to the periovulatory stage, how the adenomyosis can affect the endometrial appearances there. So this is another example of why we need good grayscale as part of our approach to reproductive medicine. Obviously, 3D is very, very useful. I just put this one as kind of quite obvious in terms of looking at the endometrial myometrial interface, and just an example of really extensive adenomyosis, kind of obliterating that interface with adhesions within the cavity. And again, we expect to see increased blood flow with adenomyosis. Endometriosis is very, very estrogen driven, and therefore estrogen dominance would play a major effect in terms of the development of this particular disease. So those Doppler images then take us on to color Doppler SMI in particular, superb microvascular imaging. Okay, and I'll combine it to save time. I'll combine it with 3D so you can see how they both work for us in this field of ultrasound. And these are the areas that I'll cover. Okay. First thing to say is that color Doppler has had a tremendous effect, tremendous benefit in general gynecology as well as reproductive medicine. And this activity here kind of moves ultrasound from an anatomical study, a basis for anatomical study, to looking at physiological change. We'll come back to these images in a second. So here's IVF patient, endometrium developing there. Here are the follicles. And we can do fancy things. We can look at follicles. We can measure the size. We can put our color in there. But the thing is, we don't know which are the good follicles. You might have 10 follicles there, but we don't know which are the mature follicles. Size doesn't tell you that. And also, if you have an estradiol of X thousand units, you don't know which of those follicles is producing that level of estrogen. So we need another parameter to overcome that. And the parameter is SMI. And we know from studies we did 15 years ago, 15, 20 years ago, that the peripheral vascularity around a follicle reflects the activity of that follicle. And those studies are here. These are studies that we presented at ESRI many, many years ago. And if we just take the issue of follicle size and estrogens. So here's the results of that study. Here's follicle size. Here's our serum estradiol levels. Now, if we take a follicle of 21 millimeters, we see that there is 250. This one there is around 800. If we go up here, here's a follicle of over 1,000. We go back along here, we're back down to 250. You can see from there how limited measuring follicles would be in terms of assessing the quality of the follicle and the likelihood of a mature egg. If we add color Doppler onto that, and we kind of put in increasing vascularity with our SMI now, you can see that it's a far better correlation in terms of follicle appearance and estradiol levels. And that also applies to post-ovulation as well. This is a study carried out at a similar time, and we presented this work to ESRI. If we look at serum progesterones there and increasing levels of vascularity of the corpus luteum, there's a good correlation there between these hormonal changes and ultrasound appearances. And certainly if we introduce endometrial changes into these inference charts, you can see that the better proliferating endometriums, the reds, are all this part of the chart with increasing levels of corpus luteum activity. So this is why color Doppler is very, very important to us in terms of this work. And here's embryo 26 days after ovulation, and that's fine. That's, you know, we're happy to see that. But what's just as important in terms of assessing the pregnancy is to look at the ovary. We know that pregnancy is supported by good levels of progesterone. We do a lot of work with infertility, we do a lot of work with recurrent miscarriage, and we feel that the use of color Doppler looking at the corpus luteum is of tremendous value to us. Keeping on along with 3D and early pregnancy, we've got this thing about measurements. Ultrasound got this thing about measurements. You know, with this kind of imaging, you know, we should be looking more at the ultrasound. Is that normal or is it not normal? A visual thing. But we have this thing about measurements. So here's a crown rump length of 9 millimeters. That's our conventional 2D image. If we do a 3D sweep and we manipulate the 3D so we get a true crown rump length, you can see there's a significant difference in terms of the crown rump length measurement. So if we're using 2D transvaginal scanning, and measurements are so important to the world, the measurements are inaccurate, okay? And that's the kind of impression we got in terms of the number of pregnancies where we're misdiagnosing the dates, the gestational age of the pregnancy. So again, 3D is very important, very easy to use. Another thing, 3D gives us a very, very good visual appearance, as I was saying, a visual impression. So here's a pregnancy just over 6 weeks. It's very important, an active corpus luteum. And within a few seconds, we create this rendered image. And the relevance here is that we can see a nice sac, a nice trophoblastic ring there. We can see the changes there where the developing placental tissue will appear. Now, if we look at the embryo, that's the yolk sac. We know that at 6 weeks, the crown rump length is the same diameter of the yolk sac. Before 6 weeks, the crown rump length is smaller. After 6 weeks, as you can see, the crown rump length becomes larger than the diameter of the yolk sac. And so by just looking at the pregnancy, you can see the pregnancy is developing nicely. You don't have to worry about measurements. Measurements are likely to be inaccurate anyway. And certainly if you're involved with infertility, recurrent miscarriage, you are doing a lot of early pregnancy scans. And if we take this case here, see it's a heartbeat there. There's the yolk sac. And this is 7 to 8 weeks. And the yolk sac, the diameter of the yolk sac is virtually the same as the crown rump length. So we know that this is an abnormal pregnancy. And this was a trisomy 18 who miscarried. She miscarried at around 10, 11 weeks. But you can see there's the yolk sac. Through the yolk sac, we can see the embryo. There's the amniotic sac there. So you can see how important 3D is to us from a visual point of view and removes the need to keep going to charts and looking at measurements are inherently inaccurate in a lot of cases anyhow. 3D also allows us to identify the chronicity of pregnancies very, very easily indeed. So here's our dichronic amniotic sac, very nicely seen with the rendered image. And here's a monochorionic twin pregnancy. And again, you can see how certain we can be the chronicity by looking at the rendered image that our 3D scan gives us very easily. In terms of abnormalities, there's been lots of lectures on first trimester abnormalities, but these have actually been around 12 weeks. We can pick up issues well before that, as you've already seen. This is, obviously normal 3D. And these images are not special. You get them very easily, within seconds. That's a normal pregnancy. We look at this pregnancy, again, 9+ weeks, and there's an exomphalus there. There's edema at the back of the neck and a trisomy 18. And we look at this pregnancy, 9+ weeks, and you can see there's abnormal heart appearances there and transverse. And again, the rendered image gives you an obvious picture of an abnormal fetus. So 3D is very important to us. It's not kind of boys' toys. It's important to us from a diagnostic point of view. Let's quickly move on to 3D itself. You've seen pictures of a double septate uterus there. It's not bicornuate. This is a bicornuate uterus. You can see the heart shape at the top there with an IUD in the wrong place. This is a unicornuate uterus. You've seen lots of pictures of anatomical malformations shown by 3D. But also 3D is very good for sorting out kind of complex situations, complex disease. This presented as a left ovarian mass, if you like, left ovarian mass. But playing around with the rendered image, we can see there's a corpus luteum within an ovary. There's the femoral end of the tube stuck to the ovary. These are adhesions here with loculated fluid. We can sort out what's going on in a complex situation. Here we have at the top of a marina coil going into the interstitial tube. These are polyps in the uterus. And this is a tubal pregnancy, actually a tubal miscarriage. But you can see the ectopic sac there. You can see vessels within the lining the sac. You can see peritubal vessels there. So this is the diagnostic information that 3D gives us in different situations. And certainly we do a lot of saline infusions, and 3D is an integral part of this now. And we put in a bit of saline, and we can see the polyps very, very nicely. We're back to our rendered image. And saline infusion is very, very important to us, not just from a fertility point of view, but also general gynae point of view. Now, we're moving on to kind of checking the tubes, and really, if you're checking the tubes, then you should also be looking at the cavity as well. You should also be looking at the cavity as well. And I just got a wink from Petra. So just, we've made changes in our approach so we can make use of SIS procedures as part of HICOSI procedures. And we're going back to using microbubbles in solution instead of foam to look at the tubes. And this helps us to facilitate 3D SIS because we can get rid of the microbubbles easier than the foam. And also we're using new catheters to really bring together these two procedures. And they should really be produced together. They're the catheters we're using. And the catheters we find are very, very useful. Improves the technique, reduces patient discomfort, etc., etc. And just very quickly, case one. So this is the foam. I'm coming towards the end, Petra. This is the foam, and you can see spill there. You can see spill there. Okay, that's spill there. But you can see how it obliterates the cavity. Obliterates the cavity. Can't get rid of that. It's very difficult to get rid of that. So we can't do an SIS on that. If we look at our bubbles, microbubbles, then follow to the ovary there. And you can see how much clearer the microbubbles are in terms of confirming spill as opposed to the foam. So that's our work in terms of looking at the tubes, movements we've made in terms of looking at the tube, looking at the cavity, and I'll just flick through these. And it brings us finally on to fly-through. And the fly-through's been of tremendous value in our unit, not just in terms of assessment of the cavity. So this is virtual imaging of the cavity, and it's like a hysteroscopy. This is really ultrasound hysteroscopy, but we can be absolutely certain that that cavity is normal. And this is actually looking at the cavity from the other way, looking from the fundus down towards the cervix. So we're absolutely sure that cavity is normal, and these actually go together. That's an adhesion there. That's the septum there. You can see how important fly-through is to us in terms of assessing what's going on in the cavity. And there's certainly a very good correlation between what we see with ultrasound hysteroscopy compared with conventional endoscopy. And it's also part of clinical communication. One of the big benefits of 3D is clinical communication in terms of trying to get your information across to the referring clinician. Sorry, we've hurried that a little bit, and thank you for watching. Okay.